Hello and good evening, everyone. My name is Jessica Roman, and I hold the distinct pleasure of acting as Program Manager for the phenomenal Center for Digestive Health team here at Virginia Mason Franciscan Health. It is my pleasure to welcome you to tonight's lecture. We present a lecture series yearly on a host of topics of digestive concerns. The Center for Digestive Health is comprised of a team of pathologists, gastroenterologists, surgeons, oncologists, endocrinologists, and radiologists who are looking to optimize care of the patient through a culture of quality, focus on access, innovations in research, and educating the next generation of caregivers. By emphasizing innovative and quality patient care, research, and education, we provide excellence in our clinical programs, including the Center for Weight Management, featuring bariatric surgery and medical weight loss, GI cancer prevention, colon and rectal disorders, esophageal, liver, pancreas, and biliary diseases, as well as IBS and motility disorders. And education and research are truly embedded in everything that we do. Our team of providers from multiple specialties work together to improve your health and well-being, teach the world about what we do best, translate cutting-edge research from lab to bedside, pursue quality initiatives to provide the very best care, and discover innovations to transform your experience. And since 1982, our national breakthroughs have impacted treatment of digestive disease at the regional, national, and international levels. And while we feel that the Center for Digestive Health is extremely special, we have been honored to be awarded numerous accolades over the years, a reflection of the hard work of our providers and their dedication to our patients. Our presenters this evening are Dr. Haroon Anwar and Dr. Mahmouda Tasneem. Dr. Haroon Anwar completed his residency in laparoscopic and gastrointestinal surgery fellowship at the University of California in San Francisco, adding a fellowship in surgical critical care at the Mayo Clinic in Scottsdale, Arizona, before joining Virginia Mason Franciscan Health in 2012, where he currently serves as the medical director of bariatric surgery. Dr. Mahmouda Tasneem completed her medical degree at Madras Medical College in Chennai, India, and following her residency at Michigan State University, she joined Virginia Mason Franciscan Health in 1998, where she specializes in internal medicine and focuses on preventative care, and currently serves as the medical director of our medical weight loss program. We are so honored to have both Dr. Anwar and Dr. Tasneem speaking this evening and look forward to engaging in discussion with them during our Q&A session following their presentations.
Good evening, Jessica. Thank you so much for that introduction. It's a pleasure to be here today to talk about medical weight loss. I'm Dr. Tasneem. I'm the director of the Medical Weight Loss Clinic at BMFH. So what do we offer at BMFH? We have medical weight loss management clinicians, we have bariatric surgeons, we have registered dietitians, we also have gastroenterologists, and we partner with YMCA to help us with getting our patients more active. These are our locations, and I'd like to bring your attention to the pink dotted lines. Those are the places that we have medical weight loss clinics, and we are spread in every clinic. At least one provider practices obesity medicine. So this is our team. We are both at Franciscan Medical Group and at Virginia Mason Medical Center. So what is the medical, what do we do different in medical weight loss clinic? We assess your dietary, we make a good thorough dietary assessment. We offer weight loss medications when necessary. We collaborate with sleep medicine evaluation and get that treated. And we also collaborate with other specialties like hepatology if that is needed. And most importantly, like I said, we partner with lifestyle change programs like the YMCA. So when you see somebody like me at the clinic, what do? The first thing is we measure how is weight measured? We look at what's called the body mass index. And the reason we look at it is because that helps us determine what category of treatment options you're going to be faced with. Especially if you have a BMI of 30 or above, you will qualify for weight loss medications. But if your BMI is lower, but you also have what we call a comorbidity or associated chronic disease, then you may qualify for medication. So that's why it's very important to really measure your BMI. This is just a little slide that kind of reviews what I just said. And if you look at the little, these boxes down here, that categorizes you as stage 1, stage 2, 2 and 3. And basically it says when you're stage 1, it's mostly you do behavioral changes to help you lose weight. But as you go up the stage, along with the behavioral therapy, you can qualify for either medication or surgery depending on your BMI. And my colleague later will be talking more about what is the BMI necessary for weight loss surgery. So once we figure out what your BMI is, the next step, what we need to do is then look for, do you have other medical issues? Because the primary goal for weight loss is to help you get more active and have more mobility. That is to improve your lifestyle. So quality of life, that's what we're looking for. The second biggest thing is to help resolve other chronic illnesses like prediabetes, diabetes, high blood pressure, congestive heart failure, depression, arthritis of the knee and hip, and liver disease. So in the weight loss clinic, even 5 to 10% of your body weight loss from your baseline, actually we think it's very, very beneficial. So for example, this slide actually shows that when you start losing weight, even the smallest weight loss for you, even 3% weight loss has some benefit. And as you keep going down this arrow, the benefit becomes more and more. So if you look at the first 3% weight loss, your blood sugars get better. Your cholesterol gets better between 3 and 5. And then if you go down, if you look at 10%, your quality of life measures gets really good. And then by the time you get to 15%, your cancer risk starts slowly going down. So that is kind of what our focus is. Our focus is to help you get healthier. So once we figure that out, then the next thing is we focus on what is your barriers? What is it that is making it difficult for you to lose weight? And so we focus on that. And the main things is we're focusing on dietary goals. So for instance, the first goal for us when we see our patients is to help reduce your daily calories by 500 calories or about 3,500 calories per week. Now, if you can't do that, we help you go down to about 300 calories. If you can't, then we go down to 200 and we slowly work you up to get you to 500 calories. And then we look really into what portion sizes you're eating, what is the quality of food you're selecting. Then we do a deep dive into your snacking habits. And then we look at your daily intake of added sugars. We look at how much sweetened drinks you're having per day or per week. And then we're looking to see when your last meal is and what are you doing after your last meal. And lastly, your daily alcohol use. So when we come to your daily calories, our goal is to get you to eat a healthy plate as much as possible. I really like this diagram because it depicts what we all should be doing on a regular basis. And unfortunately, we don't. But even if you can do it 2 days a week, if you can start there and then slowly build up, it's actually going to make such a big difference. So for example, if you look at this, in your plate, you divide it into half, and then in the other half, most of it should be a vegetable, and then a small fruit portion, and then the other half is half of the grains, and this is where you put your pasta, your rice, all the things that is carbohydrate will fill this portion, and then a small portion of healthy proteins, and which can be like a fish or broiled chicken, something that is healthy choice. Or if you're a vegetarian, beans can come in this place or tofu can replace this. So like I said, do the best you can with this. The next thing is when we talk about vegetables, we said at least half your plate or little less should be of vegetables. Try to choose non-starchy vegetables as your guide. And this shows the different colors of vegetables that you can get, and they are all non-starchy. So preferably your vegetable should not be a potato because that is a very starchy carbohydrate. I love potatoes, but we should avoid it as much as possible. It's easy to cook, but we should still avoid it. But anyway, this gives you a really good selection of vegetables that you can use. And you can use multiple vegetables. And you don't have to, I hear this from patients all the time, where's the time to clean and cut? And I'm like, don't clean and cut. Get frozen vegetables. They are as good as your, fresh vegetables. Have a packet of frozen vegetables, open it up, saute it, and put it on your plate. Then once we talk about calories and we talk about what kind of foods to eat, the next focus is on snacking. Most of us, this is where we fall short. Our calories most of the time comes from our snacking and the choice of snacking we make. So usually it's about 3 to 4 snacks per day between your meals. And sometimes patients eat only 2 meals and they fill the third meal with snacking. And unfortunately, when you do the snacking, you eat way more than what you would eat at a meal. So the first goal is to really eat 3 meals and cut back on your snacking. And this is just an example to show, we think like, oh, nuts is good. But what you don't recognize is 1 handful of nuts is close to 340 calories. And some of us eat 2 handfuls of nuts, then you are snacked on 400 calories, right? But then I have patients telling me, but that's healthy proteins. And I'm like, yes, but you already get your proteins in your food. So do you need extra proteins? And these are the questions you have to ask yourself. So this is just kind of giving you an example. And then, my advice to my patients is try to remove one of your snacks that is too dense in calories and replace it with a fruit and another snack with a vegetable. And maybe the third snack, you can choose one of the things that you're already eating with the goal to reduce that completely. And then the next focus is actually added sugar. This is the goals. The goal is to get women to keep their added sugar to less than 25 grams per day, which is actually very generous. It's 6 teaspoons of sugar. Remember, each teaspoon is about 4 grams of sugar. And for men, to keep it below 36 grams of sugar a day. The average American is eating close to above 50 to 100 grams of sugar a day. So our focus is to really try and get that down. And honestly, sugar is hidden in everything we eat. So I always recommend that look at your labels and look at the serving size and then look at the sugar content and really cut it down. The biggest place where sugar comes in is the sodas and the sweetened drinks. And this is just an example of commonly, patients commonly drink this. We all thought vitamin water was really good. It turns out it has 8 teaspoons of sugar. And remember, in women, you can only have 6 teaspoons. You're already doing extra 2 teaspoons of sugar there. And then if you look at the Mountain Dew, 19 teaspoons of sugar a day. So please be careful about that. And then the last is, like I said, alcohol. With the pandemic, the alcohol, because most of us stayed at home and we were more relaxed and we didn't have much to do, the alcohol consumption slowly went up. So I'm encouraging everybody to look at the alcohol intake because that is another place where you have hidden calories as well as hidden sugars. And this just highlights some of the sugars that are hidden in some of the alcoholic drinks, especially the cocktails. If you look at your margarita, it's 250 calories. So please take a look at that. Once we're done with dietary goals, our next goal is to actually look at your activity. And my mantra, my goal is start simple. And don't get overwhelmed. Any place you start, even 1 or 2 days of activity is better than nothing. So, but our ultimate goal is, and I'll tell you what that should be, but for now, just start where you are. And if you know that you need to walk more, ask yourself, be more specific. Ask yourself, with your lifestyle, with everything being so busy like it is, with children and running the house and having a full-time job, which days of the week can you find some time? And corner it down. For example, if you say, this week I'm going to walk around the office park for at least 15 minutes during my lunch breaks on these 2 days. Once you make a commitment, stick to it. That's what I do. I have my patients ask me for, very specific. I'm like, tell me exactly how many days you can walk. And whatever they say, I put it down, and then I tell them, I'll hold you accountable to this. When you come back to see me, we're going to talk about this. So the more specific you are with your goals, the better results you're going to get. What is our goal with activity? This is where we want you to land eventually. We want you to start slow, but we want you to build it up to 150 minutes of moderate intensity exercise. And these bubbles actually show you what these exercises are, with 2 weeks of resistance training. And the resistance training even can be sitting in a chair using a band, using your own weights like doing yoga or lifting weights. Any of them will be fine. And this, I really like this slide because it brings a few things to home. It takes really about 5 minutes to eat a 500 calorie rich diet. Like, for example, if you have a large bagel with cream cheese, that's about 500 calories. But to expend that calories will take you 2 hours of walking. And so this kind of really breaks down how many hours of hiking, gardening work you need to do and how many calories you can burn. So, if you're going for a party and you know what's going to happen, you need to keep in mind so that you can be aware and then use more activity to kind of make sure that those calories you get rid of. And then I like this slide because it really talks about a good night's sleep, right? I mean, more and more, because of our 100 channels and amazing entertainment, especially in the evening, we are becoming more and more sedentary as a nation because we have so many things to watch on television. And then what happens is we eat dinner relatively early, around 6 o'clock, but then we stay awake till 12 or 1 because we are so consumed with watching television or playing games. And that cuts on our time of sleeping. And then we get up in the morning and rush off to work. So this study actually shows that even increasing your sleep by 1.5 hours results in 7% increase in daytime activity, 14% decrease in overall appetite ratings. And what I really like is 62% reduction in sweet and salty food, which is your snacking. And for this reason, you really need to pay attention to your sleep. Last, not the least, is weight loss medications. Of course, we offer weight loss medications, but it's not for everybody. And the weight loss medication is really just a tool. By itself, it may help you lose about 3%, maybe 5%. Even the best medicines will get you there. But what you do with the medicine, if you did the dietary changes we just talked about, and if you did the activities and you slept better, then you can get a lot out of your medication. So it's good to remember that. And unfortunately, medicine is not for everybody. So your doctor will really, your provider will look into it and tell you if you qualify or not for those medications. At the present time, there are 5 FDA-approved medications. The first 3 are injectables, and I'm sure everybody's heard about Zepbound, Wegovy, and Saxenda. The last 2 are oral medications. All of them, have a place. What they all do is they help you get better with your behavioral changes that we just talked about. It helps you curb your appetite. It helps you with less hunger and craving so you can actually focus on losing weight. What is not so good about the medication is they all have side effects. Just because if it works for one person doesn't mean it'll work for you. And then it needs to be taken for lifelong. And so when you stop, it's just like a chronic illness. When you stop the medicine, the weight comes back. And the last but not the least is really, really expensive. And now, because it's popular, we're not even able to find some of these medications. So that's kind of what we are battling with. So like I said, some of the insurances like Medicare and Medicaid do not cover these medications. And commercial insurances that were covering it are also dropping this this plan now because it's really getting to be expensive. So this is just was out last month on the Wall Street Journal, telling us that patients are losing these drug plans. Even the employers that were covering it are not covering it anymore. So I'd like you to keep all this in mind. If you choose to come and see the weight loss providers, the first thing I'd recommend is to check with your insurances if weight loss clinic visit is covered. And the second thing to check is if any medication is covered, because that will really help you have a very productive conversation with with the weight loss doctor. And also remember that quite a lot of primary care, your own primary care physician is also practicing weight loss medication. So start with them, find out, if they can do something, they can help you. And if they say no, then you can have them refer to one of us and we'll gladly see you. Thank you. Now my colleague, Dr. Haroon Anwar, who's the bariatric surgeon, is going to give a talk on bariatric surgery. Thank you so much for your time and your attention.
Thank you, Dr. Tasmin, for that nice review of medical weight loss options. I'm going to move forward now with talking about surgical weight loss options. As mentioned before, my name is Dr. Haroon Anwar, and I am the medical director for bariatric surgery at Virginia Mason Franciscan Health. So we'll do a quick overview, and we already heard from Dr. Tasneem about the lifestyle changes that are very important, as well as some of the newer weight loss medications that are becoming more important for obesity and weight management. I'm going to spend time now talking about bariatric surgery and discussing what the options are for people interested in that. So as a reminder, obesity is defined by a number that we calculate called the body mass index. And the body mass index is a ratio of your weight to your height. We categorize people based on their BMI into different categories. As you can see on the slide, normal BMI is 18 to 25, and we start talking about people being obese at a BMI over 30. We're often talking about surgery for obesity when we have people with BMIs over 40. Obesity is really becoming a global pandemic, and this was just published in the Lancet Journal in February of 2024, a global study performed by researchers in England and the United States, as well as World Health Organization. Estimates are now that there are 1 billion people who suffer from obesity globally. Since 1990, obesity has more than doubled in adults and quadrupled in children and adolescents. And at this point, 43% of adults globally are overweight. On the right side, you see two pictures. The top picture is a depiction of what was happening in 2016 in terms of obesity rates. The darker the color, the more rate of obesity. So you can see 2016 at the top, already some dark colors, particularly in North America. But as we move forward, this is the expectation or prediction of what will happen in 2035. And we see the dark colors darkening and then more colors filling in the global map. And so we are really facing a serious pandemic globally. If we drill down to the United States, it's been a critical public health issue for a number of years. We know from our data it's the second leading cause of death and affects, like we said, about 40% of the population. It's a problem because it's linked to many other chronic illnesses. We'll talk a little bit about that in a second. And it's also associated with higher mortality risks. Finally, it does affect people's quality of life, emotional, mental outlooks, and different things. So it really impacts people in a number of ways. And this is a map of the United States, again, color-coded with the darker colors being higher rates of obesity. If we drill down directly into Washington State, you can see we're a little bit better off than many of the states in the country, but still, as of 2017, over a quarter of our population struggled with obesity. It affects people of all age ranges. It affects people of all ethnicities, and it's pretty equally distributed between men and women. So how does it affect your health? Like we mentioned, significant increase in development of other medical illnesses and significant impact on one's quality of life. Here's a slide with some of the pictures or diseases that are associated with rising weights, with obesity. One of the most common ones, start up at the left upper part of the screen, sleep apnea. And many people are already on treatment for sleep apnea. As we go down, liver disease, it becomes pretty prominent, and in particular what's called steatohepatitis or fatty liver disease. And for some people, joint issues like arthritis or gout become serious problems. And in fact, many people are referred to us by their orthopedic surgeons because they need to lose weight before joint replacements. Certain cancers are more common with obesity. Often these are cancers that are driven by different hormones in the body, and as our weight goes up and obesity rises, we have higher levels of some of those hormones in our body, which we think are driving some of these cancers. Heartburn, acid reflux is very common, depression, and the big category here is cardiac and metabolic issues. This is diabetes, high cholesterol, and high blood pressure. And these are three of the leading factors leading towards heart disease. Heart disease is still the #1 killer in the United States. So if we can do something to impact and improve these three, we can improve heart health and thereby improve life expectancy. And so we have fairly well-defined criteria or indications for who can qualify for surgery. These were based on a consensus statement from 1991 from the NIH. And these were if people have a BMI over 35 with one or more of these associated medical comorbidities, they're a candidate for surgery. Or if you have a BMI over 40, that alone is an indicator for surgical intervention if the person so chooses. Now, these criteria have been modified by our national organization for our metabolic and bariatric surgery, but so far, really, they haven't been picked up yet by the insurance companies, but I think that will slowly change over time. As a reminder, I think Dr. Tesmeen already showed this slide, but we have 3 centers in the Puget Sound where we perform our weight loss surgery. We have St. Michael Center on the peninsula, Virginia Mason Medical Center here in Seattle, and then St. Francis in Federal Way. And so we're well spaced throughout the Puget Sound to help meet those needs. This is our team. I wanted to introduce everybody to the whole team. We have a total of 7 surgeons. We have 3 located at our St. Francis campus in Federal Way. We have 2 now at Virginia Mason, as Dr. Deal has kind of shifted down to St. Francis. And then we have 2 surgeons in St. Michael's Medical Center out in the peninsula. And all of our centers and surgeons are, certified through the ASMBS, and we have 3 centers of excellence through the ASMBS program, which certifies all the hospitals nationally for excellence in bariatric surgery. We know that weight loss surgery is effective, and we see this on the next slide here, where as you lose your weight, you tend to improve some of the medical problems that we just talked about previously that are associated with a higher weight. So we can see, for example, sleep apnea improves in about 3/4 of people. High cholesterol improves. High blood pressure significantly improves. Over here we have diabetes with significant improvements in diabetes with the weight loss surgery alone. So we're not saying everything goes away and you're back to perfect health, but things improve significantly and people are able to come off of medications or reduce medications for certain illnesses. So, how is the surgery done and what are the different procedures that are performed? We'll talk about that next. So, briefly, as an overview, what to expect with weight loss surgery or bariatric surgery is we definitely expect people to lose a significant amount of weight. It varies a little bit depending on which procedure somebody chooses, as well as the individual undergoing surgery. As mentioned before, we expect significant improvement in many of the medical illnesses that are associated with obesity. We anticipate people eating fairly regular foods, healthy choices, but smaller servings. For a lot of folks, because of hormonal changes that happen in the body after surgery, there is a significant reduction in hunger and a significant reduction in the urge to eat. And our long-term goal, as with the first talk, is to establish healthier habits and behaviors to encourage a healthy lifestyle for longer longevity and for long-term health. We do recommend, in the end, also that people take multivitamins and supplements to make sure you're getting enough of the micronutrients that your body needs to function optimally. So for the specific operations, there are 3 now that are fairly common throughout this country and worldwide, and 3 that we focus on primarily here at Virginia Mason Franciscan Health Center. First one is the sleeve gastrectomy. And as you can see from the picture on the right, what we're doing here is this is your whole stomach normally. We divide the blood vessels that attach to the stomach on the outer edge here. And then with a tube inside the stomach to help size the stomach to the proper size, we then divide the stomach with a stapler, and we remove this section of the stomach. So we're removing approximately 80% of the stomach, and you're left with a skinnier stomach that's more like the size and shape of a banana. Whatever you eat will go into the stomach and then down into the intestines the normal way. This procedure is what would be called the restrictive procedure. It limits how much food you can eat, but does not cause any malabsorption. So what to expect with the sleeve? We definitely expect significant weight loss. There's different ways to measure it. We have in these slides measuring it as excess body weight loss. So let's say you have 100 pounds of extra body weight and you lose 60% of that, you're going to be losing 60 pounds. As mentioned before, we definitely think you'll be able to reduce medications, increase your activity, and the nice thing about the sleeve is there are a few long-term complications to worry about. But there are some, and so some of the things we do worry about initially after surgery is you can get a leakage from where we are dividing the stomach here. You can get a narrowing if it's made too narrow in a certain segment. Again, that's why we use a tube to help size it and try to prevent that. Once the initial post-op period is over and those concerns are sort of eliminated, then we think about long-term risks, and the long-term risks are because the stomach is narrow and thin and skinny, it's hard for food sometimes to go through this because the shape has changed and the function has changed. So sometimes people will end up with acid reflux, and they may have a higher risk of getting acid reflux or heartburn than the general public. Also, the stomach is a muscle. It can stretch over time, and as it gets larger, you can eat larger portions, and you may be at risk for more weight regain in the future. The next operation is the Roux-en-Y gastric bypass. In this operation, unlike the sleeve, the first one we just talked about, nothing is being removed from the body, but in this operation, we are rerouting things a little bit. So we're going to make a small pouch out of the upper portion of the stomach here, and we're going to bypass the rest of the stomach. We'll end up bypassing, maybe 90% of the stomach. The next step of the operation is that you have to imagine this part of the intestine used to be connected down here. So we've divided the intestine. We've taken the bottom segment and advanced it up to the stomach pouch and connected it directly to the stomach. Meanwhile, we take the top segment, bring it down, and connect it directly to the intestines. And what this allows is when you eat your food, it comes down the red arrow, it goes into the small stomach, into the intestines, and it follows the red arrow down. You need digestive juices from the stomach, the liver, and the pancreas in order to process your food. So those enzymes are coming down the green pathway. And after this connection, then everything mixes, and this is the segment of intestine you have for absorbing your nutrients. And we use about the top 25 or 30% of the small intestine for this reconstruction, meaning you have well over half of your intestines for absorption, which is more than you need. So this is really mostly a restrictive operation, but potentially a small amount of malabsorption as well. And what we expect in terms of outcomes for this is a little bit more weight loss than we saw with the sleeve. So with the sleeve, we said maybe you lose 60% of your extra body weight. Here, we're going to expect more like 70%. Again, reduction in medication use, more activity. If you have significant acid reflux or heartburn already going into surgery, this is a great operation because it really helps reduce heartburn, as most of the acid is made in the stomach out here, and that is forced to go down, so it can no longer reflux back up. So for someone that may have already significant heartburn or acid reflux disease, we would often choose this operation. There are, again, some potential complications that we need to think about. Early on, we worry again about things not healing and leakage or bleeding. And then long term, we worry about potential to form an ulcer in this part of the intestine, or potential to cause a blockage around this connection here, causing a blockage of the intestines. The last operation we will touch on is this one. This is sort of a newer one. It's called the single anastomosis duodenal switch, or SADE. And if you look at the picture here, you'll see the top part here looks very similar to the sleeve gastrectomy, because this is doing the sleeve gastrectomy. We are going to remove that 80% of the stomach and make the stomach smaller. The next step is dividing the intestines right here, right after the stomach, dividing it and separating it, and then connecting the stomach to the intestines lower down. And we make that connection here. So your food will come down here and go directly into the small intestine, bypassing a segment of the small intestine. Meanwhile, the digestive juices you still make and need from the liver and the pancreas, they come down and flow down this route and then eventually meet up with the food here. So you have a shorter segment of intestine here to absorb the nutrients. And this operation actually provides the most bypassing of the small intestine. So it's the one that's at highest risk for developing malabsorption or malnutrition, sometimes manifest as diarrhea. It's also the operation that's associated with the highest weight loss. So we see up to 85% extra body weight loss for people who get this operation. It's excellent for diabetes, almost 99% control of diabetes for most people. So it's really good for diabetics with very high weights. As before, there are potential complications. We mentioned already diarrhea and potential malabsorption. If this segment of intestine is too short, then that will increase your risk of those issues, and it can lead to nutritional deficiencies. There is potential to get a narrowing here or to get a leakage after the surgery. We check for those things at the time of the operation and afterwards. And because you have the skinnier stomach like you do in the sleeve, you are at risk still for getting acid reflux or heartburn disease. Now, with all of the surgeries at all the sites that we operate on now, we do robotic laparoscopic surgery. And this really has been nice. It's bringing the latest technologies to do the same operation we used to do with open surgery, but it allows people to heal much faster because it's much less painful. People are up on their feet the same day, and most people, 95% of people, will go home from surgery the day after surgery. So finally, how safe is bariatric surgery? It's very safe. If we look at weight loss surgery, which has come a long way from when it started in the 1950s, it's become progressively safe. And some of these newer technologies like the robotic surgery and those sorts of things have really improved the safety, as well as having a national organization, the ASMBS, which promotes clinical guidelines that everyone is now using, and that's promoted a lot of safety. But if we compare complication rates with other common operations, we see that, for example, gastric bypass compares very favorably with some of these other operations. And a lot of times it's because sometimes people come in to the ER with a broken hip or a ruptured appendix, or they need a gallbladder removed because it's infected. So they're having to undergo urgent or emergency surgeries. With weight loss surgery, everything is planned and elective. Everyone is screened carefully before surgery and tested so that we can have patients in their optimal health. Obviously, some people coming in with a variety of different chronic diseases, but if we get those optimally managed, we can manage the operative risks and the perioperative risks very well. We look at the same thing. If we look at the mortality rate, we see mortality rate for weight loss surgery is actually very low relative to some of these other ones. And again, it's in large part because we are reducing the risk by doing it all electively and testing everyone in advance and optimizing health conditions before proceeding to surgery. Oftentimes there's questions about the insurance. And so BMFH has worked for many years with a variety of insurances, and we're at the point now we are covered with almost all insurances. So for Medicare and Medicaid, we're covered for those operations, and folks who have those insurance can get coverage for these operations. Same thing with Medicaid, with Molina or Amerigroup Coordinated Care. We have worked with them for years now and have a strong partnership with them. So we have patients coming with those insurances that have no problems getting approved. Commercial insurances, we work with almost all of them. Most nowadays do provide coverage for weight loss surgery as long as you meet the criteria that they go by, which often mimic the ones I mentioned earlier from the NIH. There are often processes you have to go through in order to get coverage for surgery. So you may have to have a nutrition program, a mental health evaluation. There's all the testing I mentioned that we like to do to make sure you're safe for surgery. But if you can meet all of those criteria, and the offices will help guide you through that, then you should be able to get coverage for your surgery. If you don't have any insurance, BMFH actually has a very favorable elective self-pay rate that they offer to patients as well. So basically this slide is just to kind of show what the steps would be if someone is interested in surgery. It would be a visit or consultation with one of our surgeons to talk about medical issues and start thinking about which operation somebody wants to do, to set up everything that needs to be done in terms of the testing, the evaluations, and all that. And then our offices will work with your insurance to get the approval, so it's not something that you need to do. Once it's approved, they will work with you to schedule the surgery date. We would do a pre-op visit and make sure everything is lined up, and then you basically come in and have your surgery. And like I mentioned earlier, 95% of people will go home the day after surgery. We know you can be successful. We've seen many people be very successful. It's important to remember that the operations are a tool to help you lose weight and maintain a lower weight. It does take a lot of hard work. It's not a shortcut. And the more success and the more effort you put in towards the lifestyle changes that were talked about earlier, probably the more successful you'll be in the long run. So we like this quote: you can't go back and change the beginning, but you can start from where you are and change the ending. So that's the presentation, and thank you for your time and attention, and have a nice day.